Oops.
Ready?
Yeah, go ahead. I'm sorry.
Leave it on, leave it on. Okay. You don't have to talk, right?
I just don't
Most should be
know.
on
I
it.
just don't know. Don't know. I'm
Yeah,
scared.
I know. Don't. Hey, everyone, the doctor is in. And I have my Dr. Melissa with me today in the same place. We're actually in South Africa, Johannesburg.
Right.
How cool is that, right? And it's midnight here.
Yes.
But we're right here. We're rocking. Mo's coming on and Dr. Clayton are coming on, but we are here and we have a very interesting topic to talk about tonight, which was new to me when you told me about it a few months ago, but there is such a thing as quadruple negative breast cancer.
Yep.
So, you know, this is breast cancer month. We've been talking about triple negative breast cancer month all month. We've been talking about all the things about triple negative, but guess what? There's a quadruple negative breast cancer.
Yeah.
And
Yeah.
and that, well, to me, what that means is the science is advancing. But you know what, Melissa, introduce yourself because your title was so long, I could barely fit in the flyer. I love that.
Well, let's keep it short. So my name is Melissa Davis, and I am the inaugural director of the Institute for Translational Genomic Medicine at Morehouse School of Medicine. And basically what that means is I lead a fabulous team of researchers, trainees, students, people who have their PhDs. Some of them even have MDs, and we, meaning medical doctors or clinicians, and we use techniques that study your chromosomes, your genes, how they are expressed is what we say. So when your genes are turned on, how much they're turned on,
What does that mean,
them
turned
on.
on? Well, you keep going.
Yeah. And we try to understand what that means. Like when your genes are activated, meaning when you're exposed to something like a hormone, and there's certain sets of genes that respond, to the hormone. So even like when you're growing, right, when your cells are developing and dividing so that you can stretch your bones, and when you go through puberty and the things that happen during that life stage change, those are genes that get turned on and off at the right time. And for cancer, that's also a disease of the genes, of the genome, meaning they are no longer responding the way they should. The ones that should be off are on, the ones that are on should be off. And we study why that happens and how
They
we
kind of
can
go
correct
rogue.
it. Yeah, exactly.
They
That's
kind of go
exactly
rogue
right.
and do their own thing and like not play by the rules.
Yeah, and then they make the cells do things they shouldn't do, which is continue to multiply and create a tumor.
Okay.
Yeah. So yeah, that's who I am. That's what I do. I mean, I do a lot of other things too, but for today, that's the hat I am.
That's the hat. I love it. I love it. So yeah, we're in South Africa at a research conference, really with a bunch of really smart scientists from all over Africa that are studying, similar areas of cancer. But anyway, so all right, so I think we should start with your very brilliant definition of triple negative breast cancer.
Sure.
What I have, like, what does that look like?
Well, I don't know if it's my brilliant definition, but
you always say it so well. You really do. You define it so well. I know we have you on tape doing it on our website.
Oh yeah. Oh,
so
okay.
Yeah. You've done on the show so many times, so we can.
Right now, I have to remember what I said for the clip. No. So when you get a cancer diagnosis, if you're unfortunate to do that for breast cancer, one of the first things the doctor will do is to assess, 3 genes specifically that are related to hormones. So female, usually reproductive hormones, estrogen is one. And each one of our hormones has a receptor, meaning for that hormone signal, there is a partner that takes that signal and then goes into your cells and turns on the set of genes that are supposed to get turned on when that hormone is present. And so they look for estrogen receptor, they look for progesterone receptor, and they look for this other HER2 receptor, which is human epidermal growth factor, hormone. And what happens is they actually use these techniques to stain the cells, meaning sort of like a dye that will only show up in the cells if those receptors are present. And so, depending on whether those receptors are there or not, that's when they give you a positive if they're there or a negative if they're not. And so, for those three receptors, it'll be triple negative if none of them are on your cancer cells. And unfortunately, most of the targeted therapies, meaning we
Right.
target a specific thing that we know about the tumor that's unique to everything else in your body. So, targeted therapy really rely on the presence of those receptors. We target estrogen receptor, we target HER2 receptor. And if you don't have those present, then that means those drugs that work really well when you have those receptors, you aren't eligible for those treatments.
That would be me. That would be me.
Yeah. But you're here. And
I'm here.
we figured out something for
I know.
proverbially. I didn't have anything.
No.
But yeah, so and there are a lot of different types of triple negative breast cancer because really,
And that's news. That's news.
yeah.
What does that mean? Talk about that.
Yeah. So, well, think about what I just said.
Yeah.
It's a diagnosis of exclusion, meaning
Right.
all we know from those three tests is what's not there.
Right.
What we don't know is what's there, what's present. And so what people like me and Dr. Yates have done is taken that group of triple negative breast cancers and tried to really define what is there. So we look at all the other genes that are present and we try to understand which ones of those genes are important. And if you look at that from a group perspective, from a population perspective, so if you take hundreds or thousands of triple negative breast cancer tumors and ask the question, what genes are being turned on, you'll find that there are certain groups that have a certain subset of genes that are on and off. And we started to see themes, of certain functions like immunology was one of the things that we really focused on.
What does that mean? So no, hey Mo.
Hey, Mom. Hey, Dr. Mo.
How you doing?
Oh, it's been a minute. I'm
Oh, I
good.
missed you, boo.
Where are you? Where are you?
Yeah.
I'm in Orlando at NCCN. Is my Wi-Fi patchy?
No, we're good.
Yeah.
And we're in Johannesburg, South
Mhm.
Africa. No,
Oh, we can't hear you.
we can't hear you. No, there, now we can hear you. Talk again.
Your
Wi-Fi
sound
is
is
a little
in
spotty.
and out. Yeah.
No?
A
No, a little
little
better.
breaking up a lot.
Keep going.
Oh, here, now that got better when you said keep going. All right. So yeah, so we're just kind of defining
Oh, yeah. Types.
triple negative breast cancer. And then Dr. Melissa started talking about different types of triple negative breast cancer. So that's kind of where we
Yeah. So really, they have different names that don't mean a lot yet, honestly, in terms of treatment. And that's what we're trying to focus on. So,
and this is all really new data. Is
I
it?
mean, it's about
It's not new.
It's about 3 to 5 years old, but that's the thing about science and research. Like we may find something out in the lab and talk about it amongst ourselves as scientists. We'll argue about whether it's real. We'll have to repeat it again and again and again. And then someone will say, well, maybe we should target something in that, in the new signature that you see here, like in the basal-like subtype of triple negative breast cancer, is there a target in that subtype? And so now you'll start to see people trying to focus on the pathways that are present in those different forms, but it takes some time to get from bench, from the lab benches to the bedside. Right. So there's some things in clinical trials right now that focus on, some of those targets. Yeah.
Okay, so gosh, I wish you could like take my blood now and analyze it. I mean, is it too late?
No, because well, for some of the things that we do, it doesn't matter where you are in your cancer pathway. We want to understand why you ever got a diagnosis.
I think I'm a good specimen.
You are.
Don't you think so?
Yes.
I'll give you some blood. We
Okay.
can do that.
Great. Thank you.
I know.
You
I
will
can
take
go,
it.
I can go to Clayton and Johns Hopkins, right? And he can take my blood.
I think so. We'll have to ask him.
Yeah, or I'll come to
Yeah.
Atlanta. You could take my
Yeah.
blood. I mean, I think we should, I want to analyze, I want to give it to science. I don't know if it'll make a
Okay.
difference.
No, we'll add it to the thousands that we're studying. We need more diversity. So it would be great actually
Yeah.
to add you to that. That would
Yeah,
be really
yeah,
cool.
yeah, let's take some.
We could like have a chart and point to the dot that's you.
Okay.
In the data.
I want to see what it looks like. Yeah,
Yeah,
yeah, I
yeah.
was having technical difficulties, I guess.
I see.
All right, so
Better?
quadruple negative breast cancer. That just even sounds horrible, doesn't it? I remember when I
Aw.
first heard the words triple negative breast cancer, I said, that doesn't sound so bad. And then I Googled it and then I was like, oh, boy. But like, what does quadruple mean?
That there's another hormone receptor that we were studying. So, again, we wanted to understand not only what is triple negative breast cancer, because we know what it's not, but we wanted to know what it is. And we knew that Black women who had triple negative breast cancer were not responding to the standard of care. They had a lot more complications. Some of that had to do with quality of care, timing of care. But when we started looking at those genetic signatures, like which genes are on and off, we could see a clear difference in the Black women with triple negative breast cancer, their tumors, and the white women with triple negative breast cancer. So one of the things we looked at was whether or not there were additional hormone receptors, because those aren't just, that's not the only set of hormones that your body uses.
So, you say that, I was in London last week with Dr. Shiba.
Yeah.
And I looked at 2 cells under the microscope.
Okay.
I looked at to blood cells. I looked at the blood cells and lymph node cells.
Okay. Cool.
And the white ones and the black ones look different.
Yeah, I'm not surprised.
I mean, totally different, like the shapes of the tumors, how they were like in the black cell, they were like all over the place. The white cell, they were more together.
Yeah, so they were spreading out. So they were growing in more aggressive, probably. That's what
Yeah,
we call
and then
it, yeah.
she showed me where the immune system, immune guys, whatever.
Yeah,
what do
immune
you call
cells,
those?
yeah.
Immune cells.
The
And-
lymphoblasts or something.
And the white cells had way more of those than the black cell.
Can y'all hear me? Can y'all hear me now?
Yeah, we can hear you.
Yeah.
Because I have questions. So,
I know, right?
You know-
You know. Oh, no. You know what? Can you get out, get out and sign back in.
okay.
Can you
Sure,
and
or
use your
just-
phone?
Or just go back out and sign back in. It may work.
How's that works?
Yeah.
Like if I switch to
Yeah,
my phone audio.
And yeah, so let's see what happens.
Her phone might have.
But yeah, I took pictures of the cells, so we're gonna do a post about it. But and she had shown me that before, but I was in the lab. And I had on my little white lab coat.
Yeah, your code.
And we were looking at under the microscope. She showed me like the little slab on the thing. What do you call it? On the slide? The slide.
Stand,
Yeah. And it's like, gosh, they look so different.
Yeah,
And it's
yeah.
frightening.
One of the things Dr. Shiba does is look at different markers to help us understand which white blood cells are there and like whether they're doing a good job or if they're not doing a good job.
Right.
So
Yeah, and that's what she showed me.
Can you hear
Yeah.
me now?
Yay!
All right. How y'all doing? So, because
Yeah,
it's dogma, typical, traditional dogma, especially as a surgeon, right? We understand that the experience of Black women for breast cancer is different, but I've had many a mentor and even a boss who said a breast is a breast is a, when you cut into it, it's all the same thing, right? And so what I hear you saying, Ricky, I hear you saying it, but Melissa, I hear you also corroborating the fact that something in the cells looks different, right? And is it just the aggressive, more invasive nature of it? But at the molecular level, are there cellular differences?
yes, ma'am, there are. And, you know, I guess anatomically speaking, yeah, sure, okay, a breast is a breast. I mean, you know, a soda is a soda. A water bottle is a water bottle, but they aren't all the same, you know, so we can
I
call
love
them the
that.
same thing, but they're not all the same. And if you don't understand, and if you only study one type of soft drink or water bottle, then you don't really understand everything there is to know about water bottles, right? And so I think that's where the sort of proclivity to just dismiss diversity, if you will, in our patient population,
Yeah.
because we've studied this sort of prototype patient for so long,
Mm-hmm.
you know, European,
European white, yeah,
no obesity,
Yeah.
no other diseases, you
no
know,
high blood pressure, no
exactly, you
diabetes.
know, been through the continuum of care all their life, you know, and then we study it in that specimen and we think that that is the norm, and it's not, you know, and there are differences, and there may even be a different majority, quite frankly. I mean, we think it's something that's been studied a lot as the common, or if you're a geneticist, we call it the wild type. So what's the normal version of a gene? But normal varies depending on where you are on the planet, right? So the normal version of a gene in Africa, which would be the most common version of that gene, could be a different version in Europe. Like the most common version of the same gene in Europe might be a different version of, and so, and we know that to be true with some of the more basic things like blood type. If you look, if I showed you a of A blood type, B blood type, O blood type, you would see that geographically, people in certain regions of the world are more likely to have a certain type of blood type. That's
Really?
also
Okay.
something genes, you know, dictate whether or not you're type A, type B, type O. And we just expand that into the broader space of everything. You know what I mean? We see that there are definitely physical traits that are unique to certain groups. And those physical traits also underpin genetics, genes that are on and off at different points in our development. And so then, yes, there are definitely underlying differences.
Like our hair, like our
Skin tone,
skin
your
color,
melanin,
our melanin, right?
you know? And I mean, you can, so you can't study one type of something and then expect that you understand everything about all the different types, you know, and that's really at the heart of what we're trying to say. But you know, what's also unique and beautiful about Black women, I like to think we're collecting the data to prove this, is that there's some beauty in our resilience that
At the
leads to the
cellular level. Come
susceptibility.
on.
Say that again.
There's a beauty in our resilience that leads to our susceptibility. So, you know, we only get the worst type of breast cancer,
Right?
but that might mean, you know, I won't say we only, that's not true. We don't only get the worst type of breast cancer, but
Many of us do.
yeah, like we definitely
Like a
get
third.
we get more than most other groups
Yeah.
get of the worst types of breast cancer. And so to me, that means something about underlying physiology, meaning before a tumor ever occurs, there are some differences in our biology. Check this, not just because of the differences in our genetics, but also because of the differences in our experiences and where we live. Like what you are exposed to, and that includes emotional exposure,
Stress.
right? Yeah, stress, trauma, microaggressions, you know, all those things that lead to you feeling bad can also lead to a susceptibility for a tumor to form.
Well, you know, before I had breast cancer, I always
And
had
changes in gene expression.
Exactly.
Yeah. But I always had something. I had a sinus infection, I had a yeast infection, I had you know, dry eye. I always had something. And I think it was all stress related, right?
Yeah.
And then I got cancer. And now I can tell you when I can feel it in my body.
Right.
When I feel
Because you're paying attention to that now.
Yeah.
Same. I used to just dismiss it like, oh, I just need a nap, or I didn't sleep enough, but I started telling people I'm allergic to drama. And if something stresses me out, I will quickly draw a boundary.
Turn it off, see you,
That
bye, love you.
Good. That is
I will love you
good,
from
yes.
over there, you
Yeah,
know?
yeah,
I don't
wish
need to
you
love you
well.
right here, I can love you from over
Yeah.
there, right?
Yeah, exactly.
Right, I know, I get a rash on my butt,
Oh my
pretty
gosh.
instant,
Really?
yeah,
Just from like a
Yeah.
stress response.
Yeah.
Wow. I mean, I think that's why I have vitiligo. Like when I first started seeing a couple of white spots, I was in
Yep.
graduate school, just starting out on this professional journey, and every step has gotten more and more and more tumultuous and stressful and complex and battles for everything, and it just spread.
wow.
It just spread. And then when I take
There
the
is an
seat,
association.
What'd you say,
I'm
Mom?
sorry, say it again.
Yeah,
Sorry,
What'd you
can you
say?
hear me okay? I said, I think there is an association.
yeah, oh, yeah,
Yeah.
I think,
Proven, a proven association.
yeah.
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 But even that goes back to, you know, Lauren's research about Black women who live in a high socioeconomic
Yeah.
neighborhood.
Yeah.
You know, Lauren McCullough says that Black women who live in a very wealthy neighborhood, high socioeconomic neighborhood, have a 126% higher mortality rate of breast cancer than the white women in the same neighborhood. So what does that say?
And that's not because they don't have health insurance. It's not
Right.
because they're not screening. It's because there's another level of stress that we're not even assessing as a risk factor.
Right.
You
Right.
know, it's you live in a
So-
great neighborhood, but you're not necessarily welcome.
Right.
Ooh, you preaching now. Listen,
Right.
can I ask the question? For people who have been previously diagnosed with triple negative breast cancer, is there something they should do to find out if in fact they had quadruple negative breast cancer? Is that available to them yet to get that answer?
So it can be, actually what's interesting, what we're starting to find out is, the clinical lab that does those triple negative tests, sometimes they automatically do that androgen receptor test. That's the hormone
Okay,
receptor.
so go androgen receptor, what does that mean?
So androgen is another steroid hormone that regulates body activity, primarily in reproductive systems. I don't want to go too deep into the science of what the androgen hormone does.
I know, I read
Dr.
about that as it's in men.
Well, it is, but we also have androgen.
Okay, like we have
androgen.
Okay.
So it is actually one of the things that are measured directly for prostate cancer. So they do look at androgen receptor status. And again, for the same reason, there may be a therapy that's targeting the androgen pathway or the lack of the regulation of that pathway for men with prostate cancer.
Okay.
Yeah. But some clinical labs, because the doctors know that quadruple negative tumors are more aggressive. And so they will do that fourth test, but they may not tell you, it may not be a part of even your path report that your medical oncologist, who is the person who looks at your test results and decides what's the best treatment for you, it's not necessarily something that they will consider in your treatment plan yet, because the research has not been done to show whether there's a different way to manage a quadruple negative breast cancer tumor.
We don't have a
And
drug.
that was my next question.
We don't have a drug for it.
Right. So looking for, something that we don't know what to do about is something that we don't like to do as doctors. Right?
You're right.
Doesn't mean it shouldn't be done. We have seen this with, genomic testing of all kinds.
Yeah.
Right? We've seen this with the minimal residual disease testing, right? Where we're looking to see, are there circulating tumor cells, things like that. When we don't know what to do, doctors don't like to look, at least the clinical side of things, right? That's problematic.
I mean, listen, even when we give presentations, hopefully Dr. Yates will come on because he might have a drug that he's working on, if I'm not mistaken. But even when we give talks, to doctors to let them know, like, hey, guess what we discovered? You know, the first thing a doctor may say was, okay, that's interesting. How does that change the way I care for my patients? And if I don't have a direct answer, it's like, okay, I gotta go back to clinic now.
But that may be why THC didn't work on me or whatever. That may be why the regular triple negative
Right.
drugs
Yeah.
aren't working because I have this other thing
Right.
going on that's not being treated,
You're right. I mean, obviously,
right?
obviously.
I
And-
definitely
and-
want to test my blood.
And I think that's why we wanted to look, right? Because it was clear that the standard of care, like I have this chart I show of women who have triple negative breast cancer and their health outcomes from treatment, same doctor, same standard of care treatment. And the Black women have like double the mortality rate in the same healthcare system being treated the same way. And I'm like, that tells me that the treatment plan does not work for Black women the same way that it works for white women. And
Okay,
why
say that again. Say that again.
that the treatment plan does not work for Black women in the way that it works for white women. And that's the same thing that Lauren saw. Like most of these tools don't work the same way in both patient sets. Like her neighborhood deprivation study mainly pointed out that this tool that people use to try to define whether where they live is bad for their health doesn't measure the factors that are bad for Black women's health. It measures the factors that are bad for white women's health.
Mm,
You understand what I mean? Like,
Yeah.
like we
Yeah.
captured all the factors that
Yeah,
impact their outcome, but we don't yet understand what are the factors that are badly influencing ours. And we have the heaviest mortality burden.
wow.
So we have to change our perspective. We have to shift the lens and start to capture, other information.
Which is really, a lot of what we're trying to say to pharma,
Yeah.
where we're helping them work on getting more women
Patients,
trials.
your voice is much stronger than mine. Like I said, I'll show them data and they'll say, ooh, that's nice. And I still can't do anything with it.
I don't show them data, I say, what's going on? Like I
Yeah.
yell at them, I
Yeah.
try not to yell, I try to give them a hug when I do it, but
Yeah.
I think they realize it because, we are recruiting for some trials now for TNBC, but they haven't said anything to me about quadruple negative.
We need to talk to them. I mean,
I
at the
are there any open trials for this yet?
no, but I mean, at the very least, we could do observational companion trials where we would just determine if this could help stratify or separate the groups in terms of who does and doesn't respond. And so you can at least start to get a picture of, oh, we're still not treating
Right,
that group, who are quadruple negative breast cancer patients.
wow, well, from what I'm seeing and what we're hearing from pharma, and I can't talk about the specific companies,
Of course.
but there are so many triple negative trials right now, more than I've ever seen since I've been doing this.
Good.
Mhm.
So many
That's
companies trying to
That's
come into this.
important. That's amazing.
Yeah, and I've never seen this many and people coming and asking us for help, which is really good. But I think
Yeah.
some of the smaller biopharmas may want to entertain.
I would love to. I mean,
Let's
we
figure that
have a
out.
ton of
Okay.
data. Like, we have
I have
all
two
of
I can think of right now, I'll tell you that.
Awesome. Great.
Yeah, but I think that they're all trying to figure it out. But I don't think their science is as advanced as what you're doing. But you're an
They'll catch
icon.
up. I mean,
You're an
we have to make it easier for them to manage it. What we do is very much, more meticulous than what could be done in a clinic setting. Like the turnaround time to get the level of information we have is too long for patient care right now. So we have to create a tool that'll allow them to get like an answer within an hour or a couple of hours, within a day or two, as
Yeah.
opposed to a week,
Oh,
So-
wow. That's incredible. That's
So Dr.
incredible.
Mo, do you know whether or not your patients are quadruple negative right now? Like, is that something any of your colleagues pass on to you?
Mm-mm. No,
Do you think it's worth at this point creating a test for quadruple negative?
I believe it is because I think that, and I hope you can hear me. I know my Wi-Fi is
Yeah, we're good. You're good. You're good
okay.
now.
I think it would be helpful for observational trials to look at recurrence, right? To look at response, at treatment response, both in the neoadjuvant and the adjuvant setting, right? I think that we would gain some really interesting information, and it would open the door for potential targets for even for drug therapy, if we knew that. So no, we're not testing for it yet, and again, largely because it's not yet actionable. But how will it ever get actionable until we can correctly
Right, exactly.
identify the
Well-
type, the percentage of patients, right? Because maybe it is only a certain subset of, let's say, Black women, but then what percentage of those? And what is their, what's phenotypically, who are they, right? Where do they live? How are their genes expressing? What were they exposed to? So there's so much that we don't know. And I think there's good information to collect on the clinical side of things that we should be looking at utilizing this test in order to better inform kind of the why of what's happening in Black women. And we may find that it's not unique to Black women. It may be other folks as well, right? And so who are those people?
Right.
Asian Pacific Islander, right? Are they descendants of, wherever? Like, how do we tease this out if we don't check actual patients for this, despite the fact that there's no clinical utility or there's no clinical target for it? So yeah, I think we should. I'd love
Well, yeah,
to.
also, Mo, if you think about it, maybe even though we don't have a drug for
Mhm.
it right now,
Not
but there are
yet.
other therapies. For example, maybe you shouldn't get mastectomy. Maybe you should get that double mastectomy. Maybe you should take a more an aggressive stance in surgery or radiation, knowing that there's a chemo for it. Do you know what I mean? Maybe
Or
there's other
maybe
things.
you're an appropriate candidate for some of these minimal residual disease testing that we're doing, right? We're kind of doing it
What does
on
that
everybody
mean?
sort
What
of
does that
willy-nilly,
mean? Yeah, what does
right?
that mean? Explain that.
So Natera, Signatera, like there's these companies and there are these tests that look for bits and pieces of circulating tumor cells, right? So whether it's protein, whether it's the actual whole cell, et cetera. And Melissa could probably explain it better than I could, but it's looking to see if there are signatures in blood or bodily fluid that would predict cancer recurrence. Some doctors are using it because
Yeah,
there's a test and it's available. Many of us are not, because what happens if you find it and you can't find the cancer? What do? Do you put a woman on chemo for a blood test that was positive? Is she going to actually do that? Can you get the PET scan approved? Are you going to have to sit on the phone for another hour and fight with the insurance company to get a PET scan approved because a blood test said that somebody might have something, right? It's a Pandora's box. But it's important information, and this could potentially inform things like that, right? Maybe there's a candidate or a unique subset of patients who would benefit from looking for recurrence earlier, looking in their blood, right? Looking in their saliva, looking in their
Exactly.
urine.
right.
Yeah.
Yeah, it's sort of like sorting patients, right? Like you want to know,
Yeah.
like you can't just give every patient the
The same.
same tests or the
Right.
same treatment. So you need to know which patients deserve a deeper look. I agree. Like when we did that, when we did the first study where we named it quadruple negative breast cancer, Dr. Yates and I were collaborating both in our junior years in our faculty. He was at Tuskegee, I was at University of Georgia. And we had to use publicly available data. We didn't have funding at the time. Now we both have more money than we can spend. But we saw that in that public data set, there were, a couple of hundred breast cancer patients that had triple negative breast cancer. And when we separated them by Black and white, 81% of the Black women who had triple negative breast cancer were quadruple negative compared to less than half the white women.
81%. So I told
Yeah.
Clayton to come on at 6:50, not 5:50.
Oh no.
So that's why he's not here. I'm sorry.
Wow. So let me ask you,
It's
so you
okay.
looked at
What am I gonna do?
you looked at prior like tumor tissue banks, right? Bank tissues to see.
Yeah. Well, it's the Cancer Genome Atlas, but Clayton has done follow-up studies to look in certain cohorts as well. And he'll have to describe those more for you. But we've also partnered with bio companies that do genetic testing. I can't name them, I guess. I shouldn't name them,
Oh,
but,
you can name them, you can name them. I just can't talk about homes in Charlotte. You can-
okay.
Yeah, you're fine.
Well, I don't know. I just won't,
Okay,
because I'm
maybe
not
you
sure.
Okay.
Are they brought to
yeah.
you by the letter M or the letter A or the letter
They
I?
start with the letter C, actually, the letter
Okay,
C.
gotcha. Moving on.
And they have a database where, we could look into their profiles, into their patient profiles, and, he started to see the same thing. Another thing that was interesting was, sometimes you would see, like in this recurrence you're talking about, we would see a change in the receptor status. So your
That part.
initial diagnosis may be triple negative, but the recurrence might be luminal A, ER positive,
Yeah.
or HER2 like it's not necessarily congruent when you start with triple or quadruple negative breast cancer.
I think we
Got it.
may see the same sort of phenomenon with the HER2 low, right? And I've been challenging the companies
Yeah.
that are because the way we look at hormone receptors typically has been what we call immunohistochemistry, right? You slice the tumor, thin on a little deli slicer, you put it on a microscope slide, and then you put different dyes down to see if it lights up for something. Meaning, if it has an estrogen receptor, that means it responds to estrogen. So you put the green dye down and you look to see how many cells light up green, and you actually count them and you get a percentage. So your percent of ER positivity is 95%. Your percent of PR positivity is 40%. And then the HER2 was kind of binary. It was either like 1 plus 2 plus, or it was either low or high, right? Or you were HER2 negative, or you were HER2 positive, or you were equivocal.
Yeah.
On the fence, 50-50. They put the dye down, half lit up, half didn't. So then they would send it to another company and do a fluorescent study. And then they'd look to see which ones fluoresced, that actually had HER2 activity, right? But now we're learning that there is expression of HER2 that is low. It's not just on or off, right?
Can you come on in?
You can have HER2 low.
Yeah.
And I
There's
think
a
if we
great
go back and
yeah.
look, I think we're going to find that a lot of folks that we call HER2 negative were HER2 low, right?
Yeah.
A lot of that were HER2 positive and got
Yeah.
HER2 directed therapy were so HER2 low that they maybe didn't benefit from that HER2 directed therapy.
Well, yeah, but that's what HER2 identified, right? The drug that Sheila took, right? And I think that she turned out to be HER2 low.
Oh.
Right. And it opens up a whole new treatment plan for these people.
She was in that trial.
Yep.
Here he is. I blew it.
Mhm.
I don't know what day it is. I don't know what time it is. I don't know what country I'm in.
Been doing a lot.
We're doing
Been doing a lot.
Yeah. I think
Dr.
Clayton.
Dr. Yates.
Oh, look at the
I
all-star.
don't know what day it is. I don't know what time it is. I don't know where we are.
How you doing?
Hi, how you guys?
Well,
Nice to meet you, Monique. I don't know if we met. Nice to meet you.
it's nice to meet you also. I thought we've been on a show together. I'm pretty sure we have, but it's good to see you again.
That's my old age. I'm sorry.
All good. Welcome back.
Here, I totally blew it.
Yeah, we call her
You
Dr.
guys
Mo
said-
for her Dr. Mo name.
Yeah.
Maybe.
Dr. Mo. I saw that in the email. So yeah, so sorry. Dr. Mo. Got cool.
All
cool.
good. All good. So we're
Awesome.
talking about HER2 low. We're talking about quadruple negative, and whether or not there should be a commercial test available for surgeons like me who want to maybe explore this with our patients and track this data and help to contribute to the useful body of literature that identifies these patients, even though there might not be drug targets that we're aware of, and it might not change management just yet.
We think so.
Mhm.
Yeah, we do think so. It's simple. We already do ER/PR, HER2 antibody testing. There's a lot of literature as far as cutoffs, what we consider positive versus negative, very similar to our ER status. And so, we also identified that these are predominantly the what African American women present with. So absolutely, we think AR should absolutely be added. In fact, a lot of universities, academic systems are actually using it, even though it hasn't gone through the remarks-based biomarker standardization test, but people do use it anecdotally.
Oh, you're saying a lot of big words. So AR means antigen, right? Antigen.
So AR, it's funny because when I give a talk, people mostly know me as the prostate cancer person. And then, you know, when I met Melissa, she's like, let's do some breast cancer research. And so we started doing breast cancer research. I was like, well, let's look at androgen receptors, things I know about. And what we turned out is that African American women pretty much, we thought they would be more expressed, but they actually predominantly lack the expression of the marker, which correlates with lack
Yeah.
of hormone receptors such as ER and progesterone, estrogen and progesterone. And so it
Yeah.
turns out to, you know, just add to the disparity, but it helps really, really classify those patients that need the most aggressive care. Because that's what our data
Yeah, that's
says.
what-
Really,
Yeah, that's
what
what
we
we're
were
just talking
thinking of
about.
triple negative was really quadruple
Yeah.
negative.
Mm-hmm.
So our data says that only 17% of what we thought were triple negative were really triple negative. And of the triple negative subtype, 80% of the so-called triple negative are really quadruple negative.
In Black women, but in white women, that's a lower percentage.
Yeah, in
So say that
Black
again.
women
That's
it's
what you said.
80%, but it's still high. It's still high in white women. It's still,
Yeah, it's
you
like,
know,
it's less than half, but it's still,
less than
yeah,
half.
you're
Yeah.
right.
Yeah.
Yeah.
All right, so say those numbers again. So in Black women, 80% of the women who have triple negative breast cancer
Are really
probably have.
quadruple negative. Are really quadruple
Yeah.
negative.
Mm-hmm.
I'm gonna come over when I get home so you could take my blood. I want you to test it. I want to see what's going on in
Vicky,
here.
we have you up anytime.
Okay.
And who has your tumor blocks? Do you, where, you think maybe we could add her to the retrospective study?
I don't know. I mean, would they be
If
at?
she wants to
would
be
they
added
be
to the
at Kaiser
It
retrospective
would
study.
probably be in their
it's,
archive, like their archive storage, but yeah, we could
Or
probably.
let's try to find them. They're in Atlanta.
So wait, so
Oh.
there's a retrospective study going on right now for this?
Well, for our team, yeah.
For a soundbite?
Yeah,
Gotcha.
yes, ma'am.
Good to
Yeah.
know. Good to
Yeah,
know.
so a part of Sembai, what we're doing is collecting, you know, these breast cancer cases, particularly triple negative. As we know, the African American, you know, present with more triple negative aggressive disease, which we're saying quadruple negative, and we're trying to understand that from every level. So, you know, obviously Melissa's leading our team, but you know, from social determinants, environmental genomics, and obviously the tumor microenvironment. Environmental studies, I think, is what we hope to sort of glean from these studies. This sort of the premise of this was that in our original paper, and you know, it's so funny. So I think we're talking now. So Melissa and I went back and forth on this stuff for a long time. Like, let's see how she, you know, I'll tell the story.
I wasn't even gonna say anything.
Well, you know, we're on a
Say anything.
podcast, so you know,
You all,
stories would
you
make sense.
really?
Yeah.
Spill it. Spill the tea. We want to know.
So yeah, so when we started talking about quadruple negative, and you know, I was really focused on the triple negative piece of it, and Melissa was like, "No, I think you're missing the mark." You know, so you know, as we know, that's her term, right? You're missing the mark. So you know, I'm quoting correctly.
I think that's your turn, but whatever.
And so you know, we extended this out to all women, and regardless of subtype, 81% of any subtype, regardless if it's HER2, luminal A, luminal B, or triple negative, 81% of African American women compared to only 56% of European women have low AR expression.
Wow.
So we think this quadruple negative is
low androgen receptor.
low androgen receptor. So we think this is pervasive across all subtypes, right? And you
So
know,
even if you have ER positive breast cancer, you could still have an androgen receptor.
absolutely.
Got
So
it.
you know that a lot of people, when we started this AR approach, people pushed out, well, you know, if it's ER is lost, then AR just follows, and the data's no. There's absolutely ER positive, AR negative phenotype, and that sort of is also pervasive across all the other subtypes.
Mm-hmm,
Wow. Wow. Wow.
Wow.
So
Say that, Mo.
So
Mhm.
Say what you wrote in the comment. You have a 23-year-old patient?
Oh yeah, from the Congo with TNBC.
Wow.
So are we enrolling folks on the other side of the diaspora perhaps, or is this mainly localized to sub-Saharan Africa, or what's the scope of the work you're doing?
I mean, from Congo, I think that would count in our diaspora studies, but So with Standby, we have, our study design is to try and capture, a wide scope of the diaspora. So from the UK, Black, British women, the United States, African-American women, and then multiple countries in Africa that represent East, West, and South Africa. We don't have Congo on our list, but I wouldn't necessarily turn it away for studies in general. But part of what we're trying to do is also understand the environment that people live in. Because, one of the things that we went back and forth on with the data, and I don't remember actually arguing about it. I remember Dr. Yates being very upset when the data didn't turn out the way he thought it should, because he was like, I know the answer. And I was like, that's not the answer, but it's still like a cool finding, like, it's like, no, make it this. I was like, no, this is the data, but this is the data. So
Wow.
I remember saying that a
We
lot.
went Melissa's way, okay. But
But anyway, I think we were trying to find some positivity, right? Like, we had a triple negative status, but we were trying to find what the tumors were positive for,
Right.
so we could identify something to target.
But
And
that's why we're dying.
Yeah.
This is
So-
why we're
so
dying,
what
because
we
don't have
what we
something
did
for it.
show, the positivity was EGF receptor.
Yeah.
So
You showed
not
the
only
posit-
our data, this has been corroborated by numerous other studies that in the quadruple negative phenotype, EGF receptor is really highly expressed.
Is
Yeah.
it?
It
Absolutely.
makes it more aggressive. It makes
Yeah.
it more aggressive.
Yeah.
So I got a lot of blesties in the comments. I forgot to look at you guys. They want to test their blood too, my friend Valencia.
Okay,
And
get some informed
oh, and
consent.
Valencia, we need Clayton for another session. She's my friend Valencia, but she's our awesome blestie. But yeah, we'll keep talking about this, Valencia, don't worry, girl. Yeah, and we have,
Yeah.
Hopi Faulkner. I don't think I know, do I know Hopi? She wants to be tested, so we'll get you some
Yeah,
cohort.
we'll have to give you some consent forms, some QR codes, so we can get them in the study. That would be wonderful.
All right, cool. And I think we need to
Yeah,
put
let's-
this on our PC
Let's
website.
do that. Absolutely. I think there'd be a number of folks who would be willing to sign up for this and really enroll themselves, especially if it's a decentralized trial where, they don't have to go through their institutions to participate, or they only need to get records and slides, from their institutions. That's something that I think a lot of women would do.
Okay.
Awesome.
Well,
Yeah, we're actually pretty excited. So, even when we published that first paper, you actually won't see the name quadruple negative on there because we got a lot of pushback. Why do we need another subtype? And, it's too early. And now his term has been adopted. All of the big names are using it. So we think we started a movement, right? People, sometimes when
started
people
at
publish, I
least
send
3
it to Melissa, I
movements.
say, look, they're mimicking us. But people, it's something that we put forth, and in science, you also want the validation that other people see what you see and that it's real in other cohorts and populations. And so that's also reassuring that some of the things that we sort of conceived and from our own experiences, as well as the data, the way we were looking at it, now have been replicated across multiple other cohorts, and people are really taking on the mantle. We're seeing different mutational patterns. We're seeing epigenetic changes correlated with quadruple negative. And the reason, I'm sort of bringing this to your audience is that the original subtypes that we have now, the ER, PR, HER2 status, they are all based because there is a molecular set of data that says that they're different from another subtype. And so that's crucial for us to identify, to basically substantiate quadruple negative is a bona fide subtype, but also a targeted treatment that could be applied to this patient population and be effective to sort of be a treatment modality that is absent, particularly in triple negative or quadruple negative patients.
Yeah, because we did see a distinction in outcome that was related to being quadruple. So not only was it more prevalent in the Black women, but we did see it's an earlier onset cancer.
Earlier age.
Yeah.
Oh my God.
7 years.
So,
7
yes,
years.
yeah.
7 years, so you can
So
get it
women
7
who present with AR negative present 7 years earlier.
Then triple negative.
than triple
triple
negative. Wow. Wow, so, you know, we know that the data we have is 40% of TNBC patients are under 40.
This would help explain why we're seeing these young women. Wow.
These young women, that's why I like Ari.
Mhm.
So, Dr. Mo, you mentioned it. We think quadruple negative explains the data that we thought were triple negative.
Right,
Yeah, so the quadruple negative explains it like a little bit better. Like this lack of AR, we see it, we've all seen the data, and we scratch our head, and then we try to break it up, okay, because there's some better prognostic, prognostic group within triple negative. But we also see these patients that just don't do as well or more aggressive or present in younger age, and we think quadruple negative explains that.
Mhm.
Yeah, I mean, and what I was
Wow.
telling them before you came on was the study we did when we looked at the clinical outcomes of patients who were in the same healthcare system. So in Detroit, being treated by Henry Ford Health Systems docs, in New York, being treated by New York Presbyterian Hospital docs, 20 years worth of data showing that Black women with triple negative breast cancer being treated in the same way. There was no difference in their stage, their presentation. There was no difference, in their screening in terms of whether it was a screen detected cancer or not. The difference was in their outcomes. And so that tells us that the treatments that were sort of generalizing for triple negative breast cancer don't work as well in these Black women who are probably quadruple negative patients, right? So if we can link specifically, what it is about this particular type of tumor that does not respond to what is currently the standard of care. First of all, we have to sort the population and find them, right? So like we were saying,
Yeah.
we need to first of all define who has quadruple negative and then reconsider the way they're being managed, period. And that includes trying to identify new targeted therapies that could potentially work for them. But, to also build on what Clayton was saying in terms of fighting the battle of proving the principle that there could be differences in these patient populations, we did in every way conceivable show that quadruple negative breast cancer was a real biological subtype. So he mentioned epigenetics, which at the time was not trivial, right? Like
Yeah.
something else we went back and forth on a lot, right? But we showed that the way the gene is being regulated, because one of the I guess pushbacks was the gene wasn't mutated, right? And how or why would it be differentially regulated? And so we showed that there was a specific mechanism that was breaking down in the middle of the gene being expressed from the DNA to the actual gene product. There was something unique that was, distinct in the Black patient population that was shutting down androgen receptor expression, and that some of these were regulating other oncogenes, so genes that turn cancers on. So EGFR, for instance, came out, as he mentioned, as being one of those pathways.
Wow, so if you think about it, all these Black women are getting TNBC younger. And then a lot of us are having a recurrence within a year. Mine was a year.
Mm-hmm.
My recurrence, and that's the recurrences are happening fast, right?
Mhm.
How many, we have so many, like Michelle, her recurrence came in like 16 months.
Yeah.
And then also we're getting diagnosed de novo, like Deltra, at 32.
Yeah.
So
Yeah, as well, I believe. Yeah.
yeah, I think Tia was 37, I think. I mean, her recurrence came within a year.
Lakia.
Oh, Lakia, yes.
Mhm. Yeah.
But it's like it's happening fast for us, and we don't have a drug. And I mean, like, the TAC stuff doesn't work for a lot of us.
But even knowing the QNBC status, quadruple negative status, like Dr. Mo was saying, could maybe even identify patients who are more likely to recur. We didn't have that data for the cohort that we analyzed, but that's something we could,
We did.
Dr.
That's the
Yates-
stuff.
That was the second study. We did in the second paper.
Yeah.
Okay.
Yeah, in the second paper.
What-
So in the
so what's
second
the
paper,
extension
what
of
we
that?
showed was the patients who were metastatic or recurrent, if they were triple negative. So, Dr. Mo, as you know, we normally use the original biopsy as the diagnostic tool and what we go out there, and we don't do a second biopsy if a patient recurs and become metastatic. So in this case, we actually looked at second biopsies.
Okay.
Right, so we compared the original biopsy to the second biopsy. I
Yeah.
happen to see the manuscript.
Yeah.
And what we saw was that the triple negative subtype was the most variable subtype. So even if you look at luminal A, luminal B, they over 70% of those patients that were originally diagnosed, even if they were treated or recurred or became metastatic, were stayed luminal A or luminal B. The triple negative, only 50% of those patients stayed triple negative if they became metastatic or recurrent to current disease.
Mm,
But if
Explain
they were
luminal A and
originally
luminal B.
quadruple negative,
Explain
when we
that.
reclassified the quadruple
Yeah.
negative, hold on,
Okay.
then they stayed quadruple negative, whether they became, so that is the
now
real
that's
subtype that's the great. So yeah, we published,
right.
that was the second paper.
So
on
I
this.
mentioned
Yeah.
Yeah, yeah. No, I'd love to read that because I have all sorts of questions now about things we can do in the clinic that could, you know, potentially inform clinical management in ways that I know you all criticized about a lot, right?
Yeah.
Because
We have
you
a
do
question. What is EGFR?
Hmm.
So I like to think about these terms into like go-go juice. So for example, if I'm a cancer cell, I have to be receiving nutrients or signals that make me grow. So EGF receptor is called epidermal growth factor, and it's a growth factor that signals to the cell it's time to grow, and it's also time to move and spread to away from your primary site into other parts of the body. And so it's one of
They're the
the
bad guys.
major. So you can imagine if I'm a cancer cell, I'm going to upregulate this gene or this protein so that I can have more of it so that I can grow faster.
Mm-hmm.
Okay, Toby, you got that? Wow, you guys, so what I'm hearing is that, so I have, I talked to pretty much most of the pharma companies that make these drugs. Nobody's ever mentioned this to me. They're not doing this. They're not making drugs for this. So are there, what we talked about earlier, Mo, is this a time when you should get a double mastectomy and not get a lumpectomy? Is this a time when you should do more radiation? Is this a time when you do other therapies that are more, you take a more aggressive route? Like, you know what? I know I'm not a surgeon. I know I don't know what I'm talking about, but I hate lumpectomies. I hate them because I know when people call me and say my cancer came back or I just got whatever, the first thing I say, well, did you get a lumpectomy? And I had a mastectomy and my cancer still came back, but I mean, so I can't say that it always works, but
Hmm?
I don't think Black women should get lumpectomies. And I know, Mo, we have this conversation all the time.
Yeah, and I know that's your personal preference based on your experience, your lived experience, and the those that you know and that you contact, which is a little bit of selection bias, the folks who contact you about their recurrence.
Yeah,
But
yeah.
it does beg the question, Ricky, in the time of de-escalation, because we are currently in the era, at least in the surgical literature and radiation as well, we're in the era of trying to figure out who we can do less for. The NSEMA trial just came out, and we're talking about not even doing sentinel node biopsies for people who are low risk, small tumors, ER positive, yada, 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 right? We're making a good thing better for many women. Right. And so the question of should we escalate therapy or at least not de escalate therapy for a subset of people is a really good question to ask. And so, I think it's okay to raise that question and to say, okay, should we be doing, if not more surgery, should we just not do less? Instead of doing less radiation and hypofractionation, should we go full, full court? And so I think there's a conversation to be had about that. But moreover, I think importantly looking at the systemic treatment, right? Because this is a systemic disease. Surgery is a local treatment for it, right? And it can result in
Right. We need a chemo drug. We need a drug.
Right. Radiation decreases local regional recurrence and improves survival. But what about the systemic therapies? What can we offer these women when there's no anti-estrogen therapy? Right. So how do we navigate this in terms of systemic therapy as well? So, I mean, I think it's a real valid question that I don't think we should shy away from.
I actually completely agree. So I think, Ricky and I were talking about it, and I think the first time we sort of talked, and, you remember, I think, Ricky, you remember the conversation, you said, hey, we need more drugs. And I said, maybe we need to use the drugs we have better.
Right.
Right?
Right.
You know, it takes a long time to get a drug through clinical trials and development and so forth. But I think there's an opportunity, and Dr. Moore, as you mentioned, it's particularly in the de-escalation studies, and when we start thinking about risk management, like, are we taking into consider these, race and ethnicity concerns? Like, are we taking, these prominent biomarkers? Or are we trying to group everyone in to this sort of group? And so I think that risk stratification, when we start talking about who should be treated more aggressively and which not, our sort of argument, and I think what Sambai and what Melissa's leading, is that this race ancestry, in our case, quadruple negative, matters.
And environment may matter, especially because we
Yeah.
saw an epigenetic regulation, and epigenetic regulation typically means something on top of epigenetic, literally means on top of your genes, right? So something that might be exogenous or outside of your body that gives a signal to start regulating your DNA differently. And so it then changes the way your genes are being expressed. And I mean, to the point that you're making, right? Like, if we know that Black women who get lumpectomies have, a higher recurrence, I don't know if more surgery or more
Right.
aggressive surgery is the answer, but we certainly need to have something that lets us know that even if a single cell that was outside of the margin
Right.
that may or may not have been in the, vasculature of the bloodstream or the lymph
Right.
tissue, if a single cell gets out, it's so aggressive that the tumor is going to form even from one single cell, a microscopic entity
Wow.
that
Yeah.
a surgeon would not be able to see,
Right.
but it could potentially be there, right? And but what if we knew more about the biology of the primary tumor so that we can make that prediction, like, based on these markers in your tumor, we know that, there could potentially be a recurrence here, even if one cell got away.
Well, yeah, I
Right.
call it the Rice Krispie thing. You get that bowl of Rice Krispies, you fill it up and it's kind of overflowing and you mix a mess and you clean up the mess, but that one little Rice Krispie went under the refrigerator. Right? And it came back to bite you.
Yeah.
That's actually good.
I like that.
Yeah,
I like
but if we know more about it, then, like you said, we can manage it better.
Yeah.
We can take precautions. We can do these residual, tests that you mentioned to monitor that, to stay on top of it.
Right? Those are the questions I'm asking those companies and others, is to really begin to look at that and see how we can better navigate that as from a clinical standpoint, help us to better know who to order these tests for and how to navigate this space as well. So I think that's really interesting. But yeah, I look forward to the data that's going to come out of this, because I think we can't afford to ignore or to dissuade or to call it a one-off. Like, we continue, and I beat the drum all the time about young women and breast cancer, because there is a tsunami coming that we are woefully unprepared for on the early detection side of things, right? Like, there's no guideline. There's the technology isn't there, so there's so much to do that we can't continue to ignore these questions and call them anomalies or call them esoteric. This time out for that. Like, we can get these answers in 2025. We can get these answers.
Well, we're talking about precision medicine, so
Right.
an anomaly is an opportunity. It's
Right.
not,
Right. It could be a good thing. I was on one of my pharma advocacy calls today, and one of the I think she was a clinical trial person on the call, said, do you think there's racism in cancer? They actually typed it on the screen. Do you think we have, what did she, not illicit bias, what's the other word for bias?
implicit bias.
Implicit bias. I'm like, what planet do you live on?
I'm gonna let Melissa, because I think she led some landmark.
I know, I'm like, I'm
She-
sitting there,
She
the only
led some
Black
landmark
person in the
studies
room.
that could address that. Is there racism in our cancer? And I think
Oh my gosh. Of course, I'm the
Yes,
only
there
Black
is.
person in the room. I'm like, and
She
I
said it very
had to
quickly, but
go
yes,
off
there
the
is.
Zoom. I had to turn my camera off because I was screaming.
She was like, literally, we were on the bus
She
together.
was.
She just started
My
screaming.
goodness.
Yes, and yes, there's racism. Yes, there's
Like, where have you been all your life?
like,
You know?
oh, she's
Right.
upset.
Yeah, I think the data that's sort of emerging now, because we can utilize ancestry, is that we can see what race does in an absence of ancestry and vice versa. So we can see what genes are upregulated and to contribute to our genes or ancestral or adaptation to a certain environment or an environment exposure. But we can also see that there's some other factors that are clearly driving tumorigenesis that have nothing to do with genetics.
Mm-hmm.
Yeah, we published that actually.
We-
So
Yeah.
we measured how your genetic background, your lineage, right? So
Mhm.
your inherited DNA, which is your ancestry, how there are genes that are associated with your genetic background and your ancestry. But then there were even more genes that seem to still be specific to African Americans that were different from Africans, right? So East and West Africans who shared that genetic background that we were, linking to ancestry, but we still saw these differences in expression. And it wasn't because of our European admixture either. So we have savvy people like, well, African American are mixed.
Are all mixed, yeah.
Yeah, no. We saw the European genes, we saw the African genes, and then the Black women in America had a different signature.
Mm.
And when we looked at what those genes are and what they regulate, like typically where would we see these pathways, what is it that's different? We saw like an imprint of comorbidity. So obesity, diabetes, heart disease, those pathways that are triggered by our lived experience because we're dealing with food deserts, we're
Right.
dealing with stress, we're dealing
racism.
with
Yeah.
metabolic disorders that are,
Right.
because of long-term dietary patterns or a lack of management of some of our,
Now,
other disorders.
you absolutely.
Yeah, we saw that on their tumors though, right?
But those are not
Mhm.
ancestry. So
Yep.
that's
Yeah.
that's those are race genes. So that has nothing to do with that
Those are
person's
race genes.
ancestry.
Those are race genes.
That's
Yes, race
acquired.
genes.
Yeah.
And what made it really important is that it's not there in the African patients.
Mhm.
So
Yeah,
when you have African patients, it's not there. It's only in African Americans.
Wow.
Yeah.
Wow.
Well. All right. So, we're going to celebrate DNA Day. It's April 24th. So let's continue this conversation. Black Doctor is we're probably gonna do it as an episode, not on the Doctor is In. We're gonna
Okay.
do something, because that's the 24th isn't a Wednesday. So we're trying to put that together now, and we're gonna talk to Gina Page from AfricanAncestry.com and bring her on, and she can talk about some of the stuff she's doing, but I'm gonna call you, Clayton. I'm gonna call you, Melissa.
Anytime.
Yeah. So that company is owned by my boss, by the way. So
A fellow colleague, Rick Kittles. We know him very well.
Yeah.
We know the company. We know the science. We know the people very well.
Yeah.
I know the whole
wait.
origin story.
Owns that
Okay.
company? That's awesome. I said, Rick
Yeah,
owns.
Yeah, he co-founded it with Gina.
Good, Gina.
Yeah.
I remember Rick coming by my posters back when I was a grad student at AACR meetings, right? My little research on mice and colorectal surgery. And Rick used to come by him, and Dr. Adams Campbell used to come and ask me all kinds of questions.
Absolutely.
Man, I love
Lucia.
Yeah.
I didn't know
Oh,
you know
let-
that crew.
Oh yeah, in Georgetown. I know them well. Yeah. Wow. All right.
Legends.
We hope it's been relatable, reliable, and real. That's what we do right here on Black Doctor. We're so grateful for your expertise and your inquisitive nature and your relentlessness in pursuit of truth in this regard.
Yes.
Like that is everything. And so we hope that you all who are watching, we share it. I know the signal quality was a little bit iffy, but the information in here is so good. Like if you know people with breast cancer, the people are talking about TNBC, you got to throw that in there. Like, do you know about the androgen
Right.
receptor? Do you know about
Right.
the right?
You have the 81% chance of having
Quadruple
negative
Right.
breast cancer.
And when they say, what's that? Put the link to this video. Put the link to this research. We
Yes.
put in the chat for you to share this information because you need to start asking your doctors and your clinics and your teams about this so that they can get more traction to do this type of work. So we're just grateful again for the opportunity, for the platform, for the sponsors, all the things, right, Ricky?
Yeah, we are. And yeah, if you're diagnosed with triple negative breast cancer or know anyone who is, they need to go back to the doctor and ask if they have quadruple negative breast cancer.
Yep. And if the doctor has some question, tell him to call Dr. Yates.
Right, okay, here we go. And if you want to know Dr. Yates's info, email me. You all know my email, ricky@touchbbca.org, and
Yeah.
I'll get them on. I'll get both these people's.
Yeah, we didn't introduce Dr. Yates.
I know. Who are you? Before we hang up.
Yeah,
I'm happy to be here, first of all. So thank you. Mhm.
Yeah, tell us your
Oh,
title.
yeah, what's your
Come on,
title?
where are you?
The title took up the whole flyer.
Yeah,
The
it's a lot of
John
stuff.
Lewis, come on,
Yeah,
give me a
so yeah, I'm a professor at Johns Hopkins here in pathology, in oncology and urology. I'm also the John Lewis Chair, the inaugural
Thank
John Lewis Professor and Chair, and Director of Health Disparities Translation on Global Health Equity. Mhm.
Awesome.
And he is the epitome of good trouble at Johns Hopkins.
Yeah.
That's it. You're
I
true to
try to do this. I try to get a little bit of good trouble.
Yeah.
Well, I'm gonna come over so you can take my blood. I'm gonna get you some more blood.
Absolutely, Ricky. Anytime.
let me know how I can support you all in your work that you're doing, because it's impact.
It's awesome. It's awesome.
Thank you for having us. Good
Yeah,
to see you,
thank
Dr.
you.
Thank
Thank you
you.
so
Thank
much.
you. Thank you. This is wonderful.
much.
Thank you, guys.
Right, it's
Thank
midnight.
you. Thank you
All
so
are.
much, Doctor. Rusty
Yeah.
love.
There you
Rusty
go.
love. Love you, Mo.
I love you. Safe
Take
travel.
care. See you next week.
Bye.
Take
Bye, guys.
Bye.